The liver is commonly injured in blunt abdominal trauma. It is the second most commonly injured organ in penetrating abdominal trauma after the bowel. The posterior portion of the right lobe is the most common site in blunt trauma. Why the liver? The liver is a large organ with a thin capsule, has friable parenchyma. It is fixed in position in relation to the spine, so it is prone to blunt injury. The larger right lobe is closer to the ribs. The liver has also wide pore, thin-walled blood vessels with a high blood flow leading to excessive blood loss. The causes of hepatic injury may be accidental, as I will discuss later, spontaneous, as in cases of exophatic hepatocellular carcinoma or liver cell adenoma or hemangioma, or iatrogenic during performing liver biopsy, percutaneous transhepatic cholangiography, or transjugular intrahepatic post shunt, or operative injuries. The accidental injury may be blunt, as in cases of road traffic accident or run-over accidents, blast injuries where there is waves of compression and decompression, or crush injuries. Or maybe penetrating injuries. The penetrating injuries may be high speed or low speed. The low speed, such as stab wounds. The high speed may be gunshots or shrapnels. The mechanisms of blunt injury may be simple compression against the ribs and spine, as in cases of falls from height, hits with the fists and heavy objects, or shear forces during deceleration injury. The ligamentous attachment of the liver to the diaphragm and posterior abdominal wall are evulsed, leading to liver injury. The effect of blunt injury is as follows. During the deceleration injury, lead to fractures between the anterior sector and the posterior sector, and this will lead to rupture of the right hepatic vein and significant bleeding. In case of direct blow, such as in case of car accidents, usually it affects the central part of the liver, which is the medial sector and anterior sector, lead to stellate injury. This lead to massive bleeding from the portal vein or hepatic veins and bile duct injuries. The isolated liver injury occurs in less than 50% of patients. Liver injuries associated with splenic injuries in 45% of patients. Also, the liver injuries associated with rib fracture in 33% of patients. The pathological types of injuries may be subcapsular hematoma, contusion, laceration, parenchymal disruption or fracture, hepatic vascular disruption, bile duct injury. The penetrating injury may be low velocity penetrating injury, as I mentioned before, stab wounds, percutaneous biopsy, biliary drainage and cholangiography and tips, or maybe a high velocity bullet injuries. The penetrating injuries usually associated with a significant vascular injury. The stab injury may cause a major bleeding from a hepatic vein, from the inferior vena cava, from the portal vein or hepatic artery if it involves a hilum. The gunshot may disrupt these major vessels also. Beside this, the gunshot enters the liver and make a tunnel, and beside this tunnel, it devitalizes the surrounding liver tissue due to its revolving action, leading to what's called cavitation effect. The patient usually comes to the hospital with a history of traumatic event. The physical examination is unreliable. However, altered mental status, restlessness, and disorientation may be noted. dyspnea, tachycardia, hypotension, low urinary output, and cold extremities are evident. Abdominal examination may show abdominal distension, wound, or bruises of the right hypochondrium, crepitus of the subcutaneous emphysema, or even cracks of the fracture ribs may be felt in the lower right chest wall. The right upper quadrant show tenderness and gardening, which later becomes generalized due to hemoperitoneum or biliary peritonitis. Shifting dullness is very late. Peristalsis may be sluggish or absent. Uh, the intra-abdominal abscess may be a delayed presenting feature. Although diagnostic peritoneal lavage has high sensitivity, its main role is when the ultrasound and CT are unavailable or in mass casualty situation. Before the procedure, nasogastric tube and urinary catheter are introduced to decompress the stomach and urinary bladder. The procedure is done under local anesthesia by and started by introduction of diagnostic peritoneal lavage catheter infra-umbilically, either by open or closed method. Then the catheter is advanced toward the pelvis. Perform aspiration followed by lavage if necessary. Recovery of 10 milliliter of blood is considered positive and the procedure is terminated. If no blood aspirated, do lavage by infusion of 1 liter of normal saline and roll the patient from side to side to increase mixing. After about 5 minutes, the saline is drained. The saline is drained by placing the container on the floor and allow the peritoneal fluid to drain by the effect of gravity. 10 to 20% of the infusate may be sufficient for both gross and microscopic determination. Send 10 milliliter sample to the laboratory for cell count analysis and another 10 milliliter for enzyme analysis. Standard criteria for positive diagnostic lavage: aspiration of at least 10 milliliter of frank blood at the initial aspiration or bloody lavage effluent are considered positive. The diagnostic criteria of the fluid obtained: red blood cell count more than 100,000 per microliter, white blood cell count more than 500 per microliter, amylase level more than 20 international units per liter, alkaline phosphatase more than 3 per international unit per liter. Detection of bile or bacteria or food fibers. Next, fast examination means focused assessment with sonography for trauma. It is a rapid bedside ultrasonic examination performed by surgeons at the time of presentation. It accurately diagnoses the hemoperineum and leads to fewer diagnostic peritoneal lavages and can lead to fewer CT examinations. Fast examination is indicated in cases of blunt abdominal trauma, stable penetrating trauma, and to assess the degree of intraperitoneal free fluid. Uh, Fast can be performed by utilizing four views: the Morrison pouch view, the pelvic view, the perisplenic view, and pericardial view. Here we can see the free fluid in the hepatorenal pouch or Morrison pouch, and the liver is floating in this fluid. Free fluid in the right upper quadrant or in right upper quadrant and pelvic recess suggests hepatic injury. CT scanning is the procedure of choice for diagnosis and localization and grading of the hepatic trauma and also used to monitor the non-operative management and healing. CT criteria for staging liver trauma uses the American Association of Surgery for Trauma Liver Injury Scale and classify them into 6 grades. Grade 1, there is hematoma, which is subcapsular, occupying less than 10% of the surface area of the liver, or laceration, which is parenchymal, less than 1 centimeter in depth. Grade 2 includes hematoma, which is subcapsular, occupying from 10 to 50% of the surface area, or intraparenchymal, less than 10 centimeter in diameter, or laceration or capsular tear from 1 to 3 centimeter in depth and less than 10 centimeter in length. Grade 3, subcapsular hematoma, more than 50% of the surface area, or expanding or ruptured subcapsular or parenchymal hematoma. Intraparenchymal hematoma, more than 10 centimeter, and laceration more than 3 centimeter in depth. Grade 4 includes parenchymal disruption involving from 25 to 75% of hepatic loop, or involve 1 to 3 segments. The active bleeding extending beyond the liver parenchyma into the peritoneum. Grade 5 includes parenchymal disruption involving more than 75% of hepatic loop, or involve more than 3 segments within one loop. Also include juxtahepatic venous injury, like retrohepatic inferior vena cava injury or central major hepatic veins injury. In grade 6 injury, there is a complete hepatic avulsion, and this type of injury is fatal at the scene of trauma. Angiography is used for diagnosis and management. So it diagnoses the active bleeding, and in management is used for transcatheter embolization and stenting for fistulas. The management of liver injury includes resuscitation, initial assessment, restoration of the hemodynamic stability, and the decision to operate or not. Cryoprecipitate and fresh frozen plasma must be considered. The non-operative management started in 1970s in children and in 1980s in adults. The benefits of non-operative management are less blood transfusion, less abdominal infection, less length of stay, less mortality. The criteria for non-operative management include hemodynamic stability and stability achieved with minimal resuscitation, no other abdominal injuries requiring laparotomy, preserved consciousness allowing serial abdominal examination, absence of peritonism, absence of ongoing bleeding on CT. Non-operative management consists of close observation of the patient, complemented with angioembolization if necessary, and observational management involves admission to a unit and monitoring of vital signs, strict bed rest, frequent monitoring of hemoglobin, serial abdominal examination. Role of angiography control hepatic hemorrhage. In blunt liver trauma, it may be considered the first line intervention in patients with hemodynamic stability and arterial flush on CT. In penetrating trauma is to be considered in case of arterial bleeding in a hemodynamic stable patient without other indication for operative management. The indications for angiography are transfusion of 4 units of red blood cells in 6 hours, or 6 units of red blood cells in 24 hours without hemodynamic instability. The criteria for operative management are hemodynamic instability, multiple transfusions requiring more than the blood volume, development of peritonism, active arterial flush on CT, interventional techniques have failed, and penetrating trauma. The operative management usually indicated in grade 4, 5, and 6 injuries. The goal of operations is to arrest hemorrhage, and the initial control of hemorrhage is done by manual compression and perihepatic packing. The operative management can be summarized in 4 P's. Number 1, push. 2, pringle. 3, plug. 4, pack. Push means manual compression by gauze around the site of injury. Pringle maneuver means inflow vascular occlusion, and this is done manually by inserting the index and middle finger in the foramen of Wencelau or the epiploic foramen and the thumb in front of the hepatoduodenal ligament, compressing the portal vein and hepatic artery. And this can be done by vascular clamp. Hepatoduodenal ligament can be encircled by Rommel tourniquet. Many materials like gauze plug, condom plug, fluff gauze, Kerlix roll, fine mesh gauze, and lab sponge can be used to plug any cavity after trauma. So how to deal with the parenchymal tears? The operative options to deal with the parenchymal tears are 1. Damage control surgery, 2. Prehepatic packing, 3. Hepatography, 4. Mesh wrapping, 5. Hepatotomy and selective vascular ligation, 6. Resectional debridement, which is non-anatomical, 7. Anatomical formal resection, 8. Omental pack. Damage control surgery. In patients with major trauma, damage control surgery avoid extensive procedure on an unstable patient, stabilizes the potentially fatal problems, and then apply the definitive surgery. So it starts in the operating theater, then ICU, again to the operating theater. So 3 phases. The goal of phase 1 is to arrest bleeding by gauze packing, removal of contamination, and rapid termination of the operative procedure. In phase 2 in the ICU, the aim is to correct the lethal triad of acidosis, hypothermia, and coagulopathy. In phase 3, it is the phase of definitive surgery. 2. Perihepatic packing. The packing control prevents hemorrhage in up to 80%. Sometimes from 10 to 15 pads may be required, and these packs removed after 36 to 48 hours if the patient is stable, and should not be removed before 24 hours. Otherwise, rebleeding occur again. Packing is not effective for injuries in the left hemiliver because there is no sufficient abdominal and thoracic walls anterior to the left hemiliver to provide adequate compression. Severe post-reperfusion injury following removal of the prehepatic pack. The main drawback of the prehepatic packing is abdominal compartment syndrome. How to diagnose abdominal compartment syndrome? Number 1, decrease the urine output. Number 2, elevated central venous pressure. 3, increase intra-abdominal pressure more than 25 centimeter water, and this can be measured through a Foley catheter in the bladder. Number 3, hepatography. Hepatography meaning suturing of the liver. In case of shallow lacerations, a running suture is enough. In deeper laceration, we use deep interrupted horizontal matrix suture. Teflon pledgets or felts are adjuvant for supporting the liver suture line field and prevent the shearing effect of the suture material. Number 4 is mesh wrapping. This technique is highly selective tight compression without increased intra-abdominal pressure. The key points are: apply a mesh under enough tension to create a tamponade effect. The mesh should be attached into two anchoring stable points, which are the diaphragmatic crus and the falciform ligament. In this diagram, the absorbable mesh is anchored to the falciform ligament and wrapped around the liver and suture anteriorly, and this is a complete wrap of the right loop, and this is a wrap around the left loop. Number 5, hepatotomy and selective vascular ligation. After mobilization of the liver and direct compression and inflow vascular control, finger fracture technique can be used to remove the devitalized tissue and then open the wound and suture the bleeding site. In this figure, after inflow vascular occlusion by Pringle maneuver by vascular clamp, including the portal vein and the hepatic artery, the wound in the liver can be opened and the bleeding point or bleeding vessel can be identified and selectively ligated. Number 6, resectional debridement. It is non-anatomical resection. It means removal of devitalized parenchyma using the line of injury as a boundary for resection. It is used also with inflow vascular occlusion as in hepatotomy. Formal anatomical resection can be done, but the mortality exceeds 50% and so performed rarely. 8. Pedicle omental flap or packing. The omental packing act well in low pressure bleeding with the advantage of low infection rates, and this is a preferred method for laceration. So after hepatotomy and removal of the revitalized part, and then secure the edges with suture materials, the pedicle omentum is brought to fill this defect and closed again. Also, the omental bag may be pulled through the penetrating tract in the liver. 9. Intrahepatic balloon tamponade. This method is used for transhepatic long penetrating tract in case of gunshot, done by using a Foley catheter and Penrose drain or Sunstaken tube. The tube passed into the tract and inflated. Radio-opaque contrast fluid may be installed inside the tube to confirm the position later. After stabilization of the patient's condition, it is removed by re-laparotomy. Another example, the inflated balloon, as you see, entered and exits from the penetrating tract. Again, Sunstaken tube can be used. In cases of massive hemorrhage, hepatic vascular isolation or exclusion is used. And this is done by extracorporeal IVC bypass. So bypassing the IVC or atrial caval shunt. Here the shunt passing through the right atrium, traversing the IVC, occluded here suprarenal vena cava by balloon, and then tied above, and then Romal tourniquet suprahepatic. So the blood is entering the tube from here and exit from here to go to the heart, and the liver is completely excluded and can be repaired effectively. The selective vascular isolation in which the Pringle maneuver used. the right, here in this example, the right portal pedicle is clamped or occluded by romal tourniquet, and above the right hepatic vein is also occluded by romal tourniquet. So the right, the complete right loop is excluded or isolated, and any trauma here or injury can be repaired. The total hepatic vascular occlusion, it is the last resort limited to a specialized center, used for extensive retrohepatic venous injury, involve clamps of the porta triad, infra and suprahepatic inferior vena cava, and used to manage the grade 5 penetrating injury. The indications for total vascular occlusion is penetrating injury, especially grade 5, blunt injury, in second stage hepatic resection or liver avulsion. And so we have to consider the total vascular occlusion when the Pringle maneuver and packing together are insufficient. Operative prognosis. The operative mortality is 10% for operatively managed trauma. Grade 3 and 4 injury is 10%. Grade 5 and 6 injury is more than 75%. The blunt trauma mortality is 27%. The penetrating trauma mortality is 11%.